So we frequently encounter enteral feeding intolerance. This in our ICU patients. This could be abdominal distension or vomiting, but most commonly this is the nurse coming to you and saying that the gastric residual volume is high and should I stop the feeding or I am stopping the feeding. So how is gastric residual volume as a tool to assess real enteral feeding intolerance? At best, it is a poor tool and many guidelines like ISPEN and ASPEN generally refrain from routinely doing it, or even if it's done, it should be only considered when it is very high, more than 500 ml. So one of the most common reason is GRP underestimates the true volume of the stomach of your ICU patients. Many times the tube lies above the level of the gastric residue, so it will not aspirate completely. Also, smaller tubes, if we are using less than 14 French tubes, do not many times collapse on a negative pressure by a syringe, and they do not aspirate the complete volume. So there is very high rate of false negatives and false positives when we use GRB for gastroparesis or gastric feed intolerance in a ICU patient. So what is a better way? So recently there have been interest in gastrointestinal ultrasound, which can be done at the bedside in ICU by an intensivist and can help us in recognizing patients who are at risk or actually having enteral feed intolerance when we are not sure with our clinical examination or GRB finding. So, what can ultrasound do? It can assess the stomach, mainly the antrum. It can assess the bowel, both large and small bowel. And recently, it has been shown that it can also assess the vessels, like SMA, which can help us in finding how our gut is functioning and whether the patient will tolerate or is tolerating the enteral feed. So, how a gastric ultrasound is done, which is the most common part of total gastrointestinal ultrasound. So, generally, in most studies, the patient is standardized to be in the right lateral decubitus position to do a gastric ultrasound, and we use a curvilinear or abdominal probe, which is kept in the sagittal plane in the midline or just to the right of the midline. And what we see is the liver, and beneath the liver, sometimes we see vessels like IVC or aorta, and in the clear vicinity, we will see a rounded structure, which is the gastric antrum. So, this is another more clearer view of the gastric antrum, which will show its multiple layers. And the fluid, in this case, it is a fluid filled gastric antrum and with some air bubbles. So, what you have to do is to get a view, freeze it, and then measure the area of the gastric antrum. Your ultrasound machine will give the area, and if you want, you can apply the Perlas formula, which has been validated in ICU patients to calculate Taylor's formula from the area to calculate the volume of the stomach. But you don't really need to calculate the volume. The area is knowing the area is enough. So you can measure the area of the stomach. So how good is uh, this measurement of the cross-sectional area of the antrum for predicting enteral feed intolerance? So there have been multiple studies and a meta-analysis, which is a recent one published in 2026. It included 16 studies, and what they found that the measurement of the gastric antral area has a very good diagnostic accuracy. That is the area under curve of 0.86 with a good sensitivity and specificity for predicting enteral feed intolerance based on the pre-test probability of 43%. What do we know pre-test probability? That is the patient is at risk, at least 43% of the patients in whom the gastric ultrasound was done were at risk of developing enteral feed intolerance, which is common in ICU. Enteral feed intolerance can be seen in up to 50 to 60% of ICU patients. So, we know how to do the test and what is its sensitivity and density. Now, how it clinically impacts our decision making. So, based on these results, what we can say that if before starting the feeding we get a negative GCSA, that is the area is small, then the probability of enteral feed intolerance drops to 15%, which is very less. However, if we get a positive or large gastric cross-sectional area, the probability of enteral feed intolerance rises to 73%, which is very high. So we have done all with these statistics, and what should be the cutoff based on various major studies when we will decide whether the gastric cross-sectional area is high or low to base our decision upon. So there are different cutoffs used by different investigators ranging from zero point 0.6 to ranging from 6 centimeter square to 9 centimeter square. And what we can clearly infer is if the gastric antrum cross-sectional area is less than 6, we can definitely say the patient is low risk of enteral feed intolerance. And we can start our enteral feed at a normal or a higher rate depending upon the need. However, if the cross-sectional area is more than 9, there is a significant risk that gastric retention will occur, and we can probably carefully observe the patient to start at a lower rate or try some prokinetics. So, based on this, what will be our proposed ICU workflow? So, step 1, we should do a ultrasound pre-feed or baseline assessment. If the gastric cross-sectional area is less than 6 to 7 centimeter, it is safe to initiate enteral feed and we can start it and then re-evaluate at 4 hours either clinically or with a repeat ultrasound. However, it is more if it is more than 7 to 7.2, there is high risk of intolerance and we should hold initiation or advance carefully after we give a prokinetic, or even if then it is not very good, then the area is still high, we can consider post pyloric feeding. Coming to other parts of gastrointestinal ultrasound, it has been tried by the in the ICU patients to measure the superior mesenteric artery velocity with the Doppler, which is not very difficult and is feasible to do in a critically ill patient, probably even if he is on a mechanical ventilator or multiple monitoring. And the concept is simple. If the velocity is low, the blood flow to the small intestine is not good, and probably patient is at risk of enteral feed intolerance. There are several other parts also for gastrointestinal infection. Most important is the intestinal structure and motility. So the authors have measured the bowel diameter, and diameter anything more than 3 centimeter suggests ileus or obstruction, and patient probably will not tolerate enteral feed. Another is uh, whether to look for peristaltic movements of the small intestine uh, while doing the ultrasound, and a low peristaltic movement suggests ileus, and patient will probably fail enteral feeding. So that's it for GI ultrasound. Thank you.